Good afternoon, everybody. I'm thankful to MSICS Society and especially Dr. Ravitra to just give me a chance to speak here. I'll speak on wound construction in SICS. Wound construction in manual small incision cataract surgery is very critical because all complete result of the surgery it depends upon this. It should be self-sealing, it should be watertight, sutureless, and astigmatically neutral outcome. Basically, the small is what I think is a misnomer because smaller is bigger than smaller. Small is still bigger than smaller. So it should be called adequate incision surgery. To be planned depending on hardness of the nucleus, amount of astigmatism and condition of endothelium. The key aspects of MSCI's wound construction is incision site and shape. The straight or front incision is made about 2 mm or 3 mm posterior to the limbus for better sealing. The tunnel architecture is very important. The tunnel should be strapped or funnel shaped structure. Funnel is what is that? Two curvilinear lines, imaginary lines on the sclera, which is very narrow at the limbus and wide as you go posteriorly. So in this particular funnel, you make incision at any site, maybe nearer to the limbus or away from the limbus, the astigmatism will be the same. So narrow on the sclera and wider inside the anterior chamber. Astigmatism is inversely proportional to the distance of incision from the limbus. As you go posteriorly, in the astigmatism will be very less. The depth, the half thickness of the sclera, say about 0.3 mm scleral incision is maintained throughout. The premature entry, sometimes it causes iris prolapse and too shallow incision leads to a buttonhole. So one should be very careful to maintain the thickness of the sclera while making dissection. The width should be what I told, small is a accommodative surgery or it is as per needed. The incision size is 6 to 7 mm in cortical cataracts and 7 to 8 mm in hard 4+ nucleus sclerosis cataracts. And in case with low endothelial cell count also, the incision should be proper or very comfortable, so to give very less damage to the endothelium. Procedural step is conjunctival dissection. Peritomy is performed 3 mm behind the limbus to expose the sclera. Scleral incision grew a 5 to 6 mm curvilinear front incision is made, which is 0.3 mm deep. Scleral tunnel dissection. A crescent knife is used to dissect forward movements towards the cornea. The blade should be parallel to the scleral plane. And as you go, once you start dissecting in the sclera and once you approach the cornea, the knife should be in plane with the cornea. The entrance into the anterior chamber, as a keratome is used, 3.2 mm keratome is used to enter the anterior chamber. Once is dissection in 1 to 2 mm. The tunnel should be at least about 2 mm in the cornea, in the clear cornea. The tunnel expansion, the incision is widened internally to form a funnel shaft. While making a decision, while making a wound, one should make the pockets in the side. Once at the end of the incision, one should make the pocket, scleral pocket, or it going up to the cornea. Side port, a small port, 15-degree blade is created for manipulating the lens, usually at 9 or 3 o'clock. Be cautious not to damage the anterior capsule or corneal endothelium. The common pitfalls, usually buttonholing, superficial dissection causes while making a tunnel, the dissection should be at one plane. If you make a hole in the scleral flap and fixed by moving a deeper, then you have to leave that one and start at the other place, at a more posterior place or a slightly more deeper. Premature entry, the knife enters the anterior chamber too early, then results in iris prolapse or poor sealing. Iris prolapse hyphema controlled by the proper depth and securing hemostasis while cautery. And if the incision is anterior, it will cause poor sealing effect, wound leak, ATR astigmatism, then the management is only to put the sutures. One should not feel shy by applying suture in such cases. If the incision is posterior, the risk of bleeding, premature entry, and difficulty in instrumentations. If sometimes the pre-existing against the rule astigmatism, there presence of superior filtering grape in case of glaucoma cases, secondary procedures, if it is a secondary procedure, previous surgical scar in aphakic eyes, intraocular lens exchange, extremely deep sockets, the temporal approach to scleral tunnel is very good and very easy to perform the surgery. The advantages of a temporal tunnel is where against the rule astigmatism predominantly exists, it should be preferred, better working space, and the red glow is better appreciated. Now a small video. Make a conjunctival incision. Kothari is done, and a front incision is made with the Bart Parker knife. And the dissection is made first in the sclera by sweeping movement, first on the front and then on the side sweeping movement, slowly and slowly, both the sides, and pockets are made on both the sides to facilitate the delivery of the nucleus. Anterior chamber is released. Made of that IOC foliage and the delivery, easy delivery of the lens. Thank you very much.
Thank you, Dr. Anil Kothari, for that excellent wound construction in MSICS. So what is main important in wound construction, which is the art and soul of the SICS surgery, the depth of the incision throughout, it should be uniform. So we would like to take 1 or 2 lines from our expert panel on MSICS wound construction. Dr. Kimea.
Good afternoon, everyone. Yeah, so the depth of scleral groove, generally we say 0.3, but the student should always see that the patient is normal height. Suppose he has hypermetropia or myopia, the depth changes. So it's not uniformly 0.3. If it's hypermetropic, you have to go a little bit more deep, and myopia will be more superficial. So there is one more thing which I want to give. And when we train students, we always say the major complication are premature entry and buttonhole, as said by the previous speaker. So basically that you have to see that the way you are going to go with your crescent, the heel and the tip should be, properly oriented. Okay, because if you are having the tip which is going downwards, you are going to have premature entry in every case. So you have to be very parallel to the sclera and then proceed. And always we have seen that when you complete the tunnel, the central first, then the chances of getting complications are lesser than if you complete, just go on towards side first and then go to the cornea. So first have that thing first, so go from the sclera in the center, complete that particular 3 mm or 4 mm incision first, and then go to the lateral sides. That will be better.
Thanks.
To have less complications. Yeah.
Thanks, Dr. Kimea, for that